So before I start, I'm a breast cancer oncologist. I only know how to treat breast cancer. I have no idea how to treat lung cancer, melanoma, and I know, but I prefer not to. So I have a quick question here. Anyone here raise your hand if you have a personal history of breast cancer, or you have a lovely ones, your best friend, family members, so you treat them as a friend and not as a professional. I just want to see, right? Breast cancer is so common. It's more than half of us. We have a lovely ones, we have a family members, we have a best friend who have breast cancer. So this is not just relevant as a professional, it's relevant as a person, right? As a mom, as a brother, as a sister, and as a friend. So this is how I just want to have a start. Okay. And by the way, they're timing me, so I'll be very on time. Oh, sorry, I moved too quickly. So first of all, I have to do my disclosure. And I was checking on the numbers. I'm impressed. So American Cancer Society just released the data this year in 2022. Risk of dying cancer continue to drop even today. And compared to 1991, sounds a long time ago, but actually I was in medical school at that time, dropped by 32%. That's significant, right? So it's only 30 years, and the risk of dying from cancer dropped from 32%. So having breast cancer today, the chance to die is way lower compared to 30 years ago. And I have to give credit to everyone sitting here. So that 32%, you own it, and you should be honored, and it should be acknowledged. Thank you, everyone, for that. Physicians, they did minimal work. It's all the nurses, okay? I just want to make sure you know that. And when it comes to that 32%, when you look at the large population, from 1991 to now, it would be 3.5 million people. Imagine, from all the work we do, non-smoking, and also the chemotherapy, prevention, early detector for many cancers, breast cancer is on the top. And we saved 3.5 million lives. Imagine, that could be yourself, that could be your loved ones. And thanks to all of you, and I'm really proud of everyone here. So, comes to breast cancer, so I just want to spend a little bit of time about incidence, how we do the prevention, and also treatment. So breast cancer is common, right? Almost everyone here have some personal contact, family, friends had breast cancer. Nationwide, every year, the number of patients diagnosed with breast cancer, 287,000 people. So almost 300,000. And for a woman to have a cancer, 31% of the chance is a breast cancer. 1/3 of the chance is a breast cancer. The second would be lung cancer, it's only 13%. But luckily, the chance to die from breast cancer is lower compared to lung cancer, thanks to all the treatment we have. And actually, compared to 30 years ago, even we treat them better, but the incidence is slowly trends up about 0.5% each year because we have fewer children, and it's very rare to start to have a child at age 18 or 21 nowadays, right? And it's common to have first child at 35 or even 40. So this is one of the reasons that we have more breast cancer nowadays. And if you look at the risk to die of cancer, of course, pink is always breast cancer, and slowly dropped. It's not as dramatic as lung cancer because of the smoking. But still, in the past some couple of years, and the risk of dying from breast cancer still slowly dropped. So one of the reasons that the risk to die from breast cancer is because of the early detection, early prevention, and early diagnosis. So, I have a lot of patients that still ask me today, I'm amazed, and they are professionals themselves. It's amazing they came to me with breast cancer, had a mass felt for 7 years, and to the point it's all over the body. They are professionals themselves, they are nurses themselves, and ask them, why you have not had a mammogram yet? Well, I'm too busy. Well, I don't have time. So, this is a This is one of the reasons that we have to encourage everyone, make sure you have your annual mammogram. If anyone is late for that, please go home, schedule that. And also another reason is we are way more aggressive doing the genetic test nowadays. So in 2019, I thought it's recent, but amazing, it was 3 years ago, maybe because of COVID. So the American Society of Breast Surgeons made a very strong official statement. For any women or men who had history of breast cancer, they should be able to have a genetic test. Before that, it's so hard to have a genetic test. You have to have a huge family history, and it's often the time not paid. And it's crazy. BRCA is a gene, and it has a patent. That's crazy. So nowadays, actually, genetic test is more available. And in my hands, for any women or men who had a history of breast cancer, genetic test is covered most of the time, and they should be aware, and it should be available. I had some patients had breast cancer 20 years ago. They have been cancer-free. We still can't update them with genetic test. And also for NCCN, they made a new recommendation. So for any age, any patients, if they have triple negative breast cancer, they should have genetic test. And also for those patients who had high risk HER2 negative breast cancer, if you want to offer them olaparib after surgery, they should have a genetic test. So I'll get into details why this is important, but when a patient came to you with breast cancer, we should think about genetic test. It's crazy. I have some patients, no family history, they are 76, had breast cancer. No one was expecting any positive genetic test, right? They can be positive. So we just want to make sure we offer all the patients and make sure it's available. And also, abbreviated breast MRI. This is a huge debate between the radiologists, breast surgeons, and medical oncologists. And there were quite some good studies in Europe. And finally, we have a data in the United States. So this is our data, not from the Europe. So this was published recently for those women with dense breast tissue. It doesn't have to be extremely dense. It can be any dense tissue, and age from 40 to 75. And when they do this abbreviated breast MRI, and if you look at the data, and actually mammogram, sorry, I'm not sure how to point to that. So mammogram was able to detect non-invasive cancer or DCS. And compared to that, MRI detected 22. So the conclusion was for those women or men don't do mammogram anyway, with dense breast tissue, abbreviated MRI actually can detect DCS and invasive cancer early. And often the time, insurance may or may not cover MRI. We all know that. So we actually developed a abbreviated breast MRI protocol that we, of course, want insurance to approve that first. And if insurance denied it, so the patients will pay about $500 out of pocket to get that done. I do have quite some patients with dense tissue. Insurance absolutely does not cover for that. So we can get that covered. If you look at that, we always want to detect early, and 9 versus 22. And the detect sensitivity doubled, right? So for those patients with high risk, dense tissue, good family history, this could be an option, and this is relatively new. And of course, after we diagnose the cancer, how are we going to treat them? So I'm going to divide into 2 parts. Early stage, we want to cure them. Metastatic stage, what's the new treatment? So only in the past week, I have 2 good friends approached me. They are physicians themselves, but good friends, my age, perfect age to have breast cancer, right? So they came to me and said, oh my God, I have breast cancer, I'm going to die, right? So I have to call them back, drop off everything. I was eating dinner, drop everything, call them back. You are fine, you are not dying, okay? Your cancer is 5 millimeter. We are going to cure you, you're going to be just fine. Your life expectancy is fine. But for early stage breast cancer, what we do is we don't treat everyone the same. For those low-risk patients, we want to de-escalate because chemotherapy is not trivial, has long-term side effects, neuropathy, cognitive impairment, memory loss, right? So we want to de-escalate. But for those really high-risk patients, we want to be as aggressive as we can. And it has been a puzzle. Why some patients are so lucky? They had lumpectomy radiation, took some pills a couple of years, and they have been cancer-free. Why some other patients, they had all the treatment, still a couple of years ago, they came back at stage 4 cancer? Not fair, right? So we are trying to be smart to pick up the right treatment for those early stage breast cancer patients. So we have to make a decision, who is going to receive chemotherapy before the surgery, who is going to receive neoadjuvant treatment, and what is going to be the best treatment after the surgery, what are we going to do for the adjuvant therapy. And for some patients, really high risk, when you are finishing all the standard of care treatment, I'm not happy, we are not done yet. So we want to do some more treatment beyond that. So we're going to tailor treatment for different patients based on the risks. So in the past couple of years, what we moved forward is we are more aggressive with new adjuvant treatment. So it makes me feel good, right? I'm a medical oncologist. It's no longer surgeon, cut it out, cured. And more important now, believe it or not. So because we offer more neoadjuvant treatment now. And for those patients, you should consider neoadjuvant treatment. When a patient has a cup, but tumor really big, those should be considered because the surgery is going to be very, very hard. Or they present with a positive lymph node, they should be considered for neoadjuvant treatment. Or they have high-risk features. What are the high-risk features? High grade, they do not have the estrogen receptor, they are HER2 positive, or they are triple negative, or they are young at diagnosis. My youngest patient is 19. So when she had breast symptoms, everyone was like, no, that's not why you have breast cancer. So she was laughed at for quite a few months. So breast cancer can happen in early age, and I have a bunch of 20-year-olds, they have breast cancer. So when they are really young age here is younger than 40. So I'm no longer young age. So with that, specifically for HER2 positive or triple negative breast cancer patient, when the tumor is 2 centimeters or larger, they should be offered neoadjuvant chemotherapy. It is wrong for the surgeon just to cut it out and send to medical oncologist later. So we want to see this patient before the surgery, make sure we talk about chemotherapy, neoadjuvant treatment prior to the surgery. And for triple negative breast cancer, one of the progress we made is immune therapy in layman language or checkpoint inhibitors. So for those patients who came in triple negative, they have positive lymph node, the cancer is larger than 1 centimeter or 2 centimeters, we want to talk to them about neoadjuvant treatment. Why? Because we can add checkpoint inhibitors, specifically pembrolizumab, into the treatment. And the data looks really good. If you look at the data, Keynote 522 was published a year or 2 years ago. And if you look at the data, the chance for them to be cancer-free at 18 months is 91 versus 85%. You know, just think about the large population. That 6% actually meant a lot to me. The longer you follow up, and this curve actually separates further. So this is why for patients, sorry, forgive me, I have to be politically correct. I cannot see women all the time because we have male breast cancer too. So I have to remind myself all the time. So for those patients with triple negative breast cancer, this is why we always want to make sure they had the chance to receive checkpoint inhibitor prior to the surgery because it does improve the disease-free survival. So I have the luxury that even before FDA was approved, before this was published, I have quite some patient has a luxury to receive the treatment. They do very well. Of course, it's not water. It may have some side effects. But we just want to make sure we had the discussion. We offer that to those patients. So this is one of the progress we made. And also, what is also important is this was just published this year, the study called Olympia. So I'm very proud we participate too. So for Olympia, it's specifically for those patients with BRCA mutation. They have to be HER2 negative. They can be triple negative. They can be ER positive, HER2 negative. So we offer them treatment, chemotherapy prior to the surgery. After the surgery, if they have residual disease, and they have different ways to, for the ER positive, they have different criteria. But at the end of the day, for those patients with BRCA mutation, high-risk disease, residual disease after chemotherapy before the surgery. And we randomize them into a group. One group received olaparib, that's a PARP inhibitor, specifically for patients with BRCA mutation, or placebo. Look at that. So a year, 2 years, and 3 years follow-up, the chance for those women to be cancer-free improved by almost 10%. So this is why, go back to the first couple of slides, NCCN recommended for any patients with triple-negative breast cancer or any high-risk cancer you want to consider olaparib, make sure you send the genetic test. If they have the BRCA mutation, we want to offer olaparib after the surgery. I actually had the luxury to offer to quite some patients. I'm very glad we are moving forward. Looking at the curve, they separate very early, and the separation stayed. So this is one of the treatment we do not want to miss. And this is new too. This was just published a couple of months ago. And also another topic we often the time run into would be for those hormone receptor positive, HER2-negative breast cancer patients. We know when they are stage 4, the first-line treatment is always endocrine therapy and CDK4/6 inhibitors, right? If your patient don't receive that, that's wrong. We always want to ensure they receive that. And what I counsel my patient is always like this: okay, why do you want to wait until you are stage 4 for us to treat you? How about we give you this treatment earlier, right after the surgery, to prevent you from getting a stage 4 cancer? Makes sense, right? So that was the Monica E study. And actually, we participated in the study too. I have quite a few patients still on the study, and we're still following them. So those are the patients, high risk, after they finish the chemotherapy radiation. And we randomize patients into 2 groups. One group, standard of care endocrine therapy, tamoxifen, anastrozole, letrozole, you name it. And the other group, on top of the standard endocrine therapy, they were given 2 years of abemaciclib. 2 years, not 5 years, not 5 years, 10 years, 2 years. And if you look at the data, it's not as impressive as the checkpoint inhibitor for triple-negative breast cancer or olaparib for BRCA mutation, because they have a specific target. This one still looks good. Actually, at 2 years of follow-up, the chance for them to have a relapse reduced by about 5%. It's still good. Those actually, the medication typically will not have too much impact on the quality of life, and specifically, the risk to have a stage 4 cancer reduced. So I did offer to quite some patients when they are hormone receptor positive, HER2 negative, when I consider them as high risk, I have to make sure I offer this to them because they potentially can reduce the risk of a stage 4 cancer later. So we talk about we want to escalate treatment, right? For high-risk patient, triple negative, you want to make sure you offer checkpoint inhibitors. BRCA mutation, you want to offer olaparib. Hormone receptor positive, you want to make sure you offer abemaciclib. But we also want to de-escalate. So for those women with only 1 to 3 positive lymph node, and the responder trial was published that in the past, for any patients with lymph node positive breast cancer, chemotherapy is a given, right? You have positive lymph node, we want to offer you chemotherapy. But this study randomized women into chemotherapy and just endocrine therapy alone. The Oncology DS score has to be 25 or lower. So it's interesting when you look at the postmenopausal women, chemotherapy did not have any benefit. And when you look at the premenopausal women, chemotherapy does have 5% of the benefit. So nowadays, what we do is if the woman is postmenopausal at diagnosis, and if they have an Oncology DS score 25 or lower, actually we don't recommend chemotherapy. But if they are premenopausal and if they have a positive lymph node, I do not even want to send the test because they benefit from chemotherapy regardless. So postmenopausal, you are lucky, you can get away from chemotherapy. If you are premenopausal, this is the price you pay to be young, you have to receive chemotherapy, right? But I just want to remind everyone, what's the benefit of abemaciclib? 5 to 6%, right? What's the benefit of chemotherapy? About 5% too, right? So this is the number I often reference to counsel my patient. Okay, if you do not want to take this CDK4/6 inhibitor, think about the benefit you got from chemotherapy. They are almost similar. Of course, we want to be smart, but here is a good news for those postmenopausal women. This is really weird. In my clinic, any of my patients came in, Dr. Yan, I have not had menstrual period for a year. Hooray, we celebrate, we are very happy. Great, you are in menopause, great, right? So when they are postmenopausal, actually, in general, the cancer is more indolent and we can be more laid back. So this is a perfect example. If someone here is menopause, congratulations. You got to celebrate. So that's early stage. Yeah, I see someone is extremely happy right now. So stage 4, metastatic. How many of you take care of metastatic breast cancer patients? A lot of you guys, right? Sometimes it's very sad, right? Regardless of what they do, they just don't do well. So we are trying to do our best to help those patients. So one of the updates for triple-negative breast cancer patient is that checkpoint inhibitor should be their first-line treatment if they had the PD-L1 expression. So when a woman with triple-negative breast cancer, metastatic, the first thing we do, what do we want to know? PD-L1, right? Do you have PD-L1 or not? So prior to 2021, so atezo was the only medication approved in that setting, and they had a cutoff of PD-L1 1%. And August 2021, actually, when they look at the data, actually, they withdraw the indication. So we no longer offer atezo to breast cancer patients. Why? I think they choose a lower cutoff, 1%. And at the same time, pembro was approved because they are smarter. They use a cutoff of 10%. So for now, triple-negative breast cancer patient, our cutoff is 10%. If it's 10%, they should be offered first-line checkpoint inhibitors. If it's 1 to 10, well, the benefit is not as much. We need to look for other options. So here is the data. Keynote 355. Yeah, they confuse us, right? Keynote 522, that's the neoadjuvant trial. 355, that's stage 4. And for those with PD-L1 more than 10%, look at the data. The data looks really good. So at 6 months, 65% of the patient, actually, they were stable, they were having response. And even a year later, 40%. So if you look at the progression-free survival, the PFS, that tells you how long they can stay on the drug, how long they're stable on the treatment, right? So pembro was almost 10 months, and chemotherapy is about half of it. So it's a good regimen, it's a good treatment. They should be offered this treatment. And after for those women, they already went through pembro, the cancer grew out again, or they had PD-L1 less than 10%, what are we going to offer? So sacituzumab govitecan was approved in that setting. So one of my patients received it right after the approval. She doesn't even know how to say it. She was like, I'm getting this sexy drug. That's how she said it. Because she stumbled her tongue when she tried to pronounce the drug. And the study called Ascent. So the study is amazing. Look at the data. This is second or third line treatment. Isn't that depressing? Look at the right line. Regardless of what you do, the treatment worked for 1.7 months, and almost everyone progressed in the first 3 months. Nothing worked. And for sacituzumab govitecan, I can pronounce that, believe it or not. And if you look at the data, and actually the PFS is almost 6 months. That's really amazing. For that patient I had, and actually she has been really stable on the same treatment for a year now. So this is one of the big progress we made. It's a good drug, not because it's sexy. It's a good drug. And also what is important is for any drug, we want to look at the overall survival. So translated in layman language, does this drug make you live longer? Yes, it does. So it's very depressing that for those patients who already received some treatment, the survival is about 6 months. That's about 6.7, about 6 months, right? This is our gut feeling for a patient with stage 4 triple-negative cancer. Typically, yeah, you have about 6 months to live. But with sacituzumab, actually, you can double it. So from 6 months to 12 months. So this is one of the drugs. After the first-line treatment, I make sure the patient sees this drug sooner than later because they help my patient live longer. So make sure you all know the drug. And for HER2 positive, we made quite some progress. I'm really proud of it because I just did quite a few publications on it, and I'm really proud of it. So October 2021, FDA approved trastuzumab deruxtecan in HER2. The name is too long. And so actually, previously, it was approved in third line, fourth line, later line. But they just had a new study, and now it's actually second line treatment options. So here's the data. The data looks amazing. So it's called Destiny Breast 03. The company is not creative. All the studies, Destiny 1, Destiny 2, Destiny 3, Destiny 11, 17. I have no idea which is which. And it's interesting that it's a second-line treatment. They call it Destiny 3. Makes no sense. They should call it Destiny 2. But anyhow, that's not my problem. So if you look at that, the data looks amazing, right? So standard of care prior to this study would be Kadcyla, right? The first line is always THP. You want to give them Taxotere, Herceptin, Perjeta. After them, put them on Herceptin, Perjeta, wish them luck. And after that, the second line treatment is Kadcyla, TDM1. And this drug, I used to call it TDXD. That's how we use it in the clinical trial setting. I call it TDXD. So if you look at the data, at 12 months, the chance for patient to be stable on TDM1 is about 1/3, 34%. And for TDXD, it's 75%. That tripled almost, right? It's really good. And also, if you look at the average PFS, that's how long they can stay on the treatment, how long they are stable on the treatment. So for TDM1, it's about 6 months. We offer you TDM1, 6 months later, I need to switch gears. I need to scratch my head again, what to do. And for the TDXD, actually, they have not even reached that number yet. It has been 3 years, and they have not reached that yet. It's great. I put you on the treatment, so I can just relax and lay back for a couple of years. I don't have to worry. So that's one of the treatments. I just want to make sure everyone knows that. It is true, though, every time when I talk about TDXD, you have to talk about pneumonitis because that's one of the side effects. But it's interesting that what we learned is if the patient already went through a lot of treatments, they have no options, you offer the patient TDXD, the risk of pneumonitis is higher. If you move it up, give them the second line treatment, the risk is actually lower. So I spent a chapter, wrote a review about that. So make sure you offer them sooner than later. And we have a whole bunch of strategies to manage pneumonitis. End of the day, for those patients on TDXD, I have no mercy. You got your CT scan for me every 3 months because I want to catch those grade 1 pneumonitis when they had absolutely no symptoms, but only have some scan results, right? We want to catch that. So make sure you scan them regularly, look for the pneumonitis. And another drug that I really like was also approved. It was almost 2 years ago now. So it was tucatinib. The reason I like tucatinib is it's a small molecule. It's very effective in treating brain mets. Okay, now I have a quick question. How many patients with HER2 positive breast cancer stage 4 would have a brain mets? 20%, 30%, 50%, 70%? Stage 4. 20? You are just being really nice. About 50% of the HER2 positive stage 4 cancer patient would have a brain mets at one point. 50%. So this is what I'm telling my nurses. If they have HER2 positive stage 4 cancer, headache, brain MI, no mercy. If they have blurry vision, brain MI, no mercy. Why? Because the chance to have brain mets is about 50%. And tucatinib is very effective in treating brain mets. This is a HER2 clan. I'm very proud because I participated in the trial too, and I still have few patients on it. Really good drug. So what that entails is if you look at the left, again, it's overall survival. It's how long they live for those patients with active brain mets. And if you look at the 2-year survival for the patient on tucatinib, it's 50%. And for those patients not on tucatinib, it's only 20%. Another question I have. So for a patient with a cancer in the brain met, so when you see the patient in your heart, you know how long are they going to live? 6 months, 12 months, 2 years? Any ideas? A patient has active cancer in the brain. What's the average survival? 6 months, right? So even for HER2-positive breast cancer, we have all the effective treatment. On average, in this study, it's 11.8 months. So when a patient has cancer in the brain, you know they have less than a year to live. That's very fair, that's legit. But in this trial, what is amazing is if you look at tucatinib, the survival was 2 years. So it doubled the survival for those patients with active brain mets. So this is why when my patient with brain mets, HER2 positive, went to the hospital and they are mad at me, I have not talked about hospice, I was mad too. I was like, no, my patient can live for 2 years, okay? They are not 6 months, they are not 12 months, they can live for 2 years. So, and also another drug was approved, not sexy, and I just want to make sure everyone knows the name, called metrituximab. It's a better form of Herceptin. I'm out of time, so I just want to make sure I'm on time. So this is the take-home message. Early breast cancer, low-risk disease, postmenopausal, congratulations. High risk, we want to make sure we offer a lot of other treatment. Metastatic, we made some good progress. Thank you all. I made it. I'm on time. Thank you all.
We do have...
Oh, so I need to do questions. Okay.
We have one in there.
Oh, okay, so I have one question. Is it recommended to give Herceptin to men with breast cancer? Yes, we don't discriminate men, even if we have very few of them here. So yes, if they are HER2 positive, yes, we want to offer all the options to them. Thank you all.